All right, with that said, I'm going to go ahead and start with our next distinguished speaker. We're going to have Dr. Edward Stehel. He is an assistant professor of radiology in neuroradiology at the UT Southwestern Department of Radiology. He earned his medical degree and completed residency and fellowship training in neuroradiology at UT Southwestern as well. The title of his presentation is Radiologic Interventions for Acute Back Pain. So please join me in welcoming Dr. Stehel to the stage.
So first, a little housekeeping, and this is for the ordering clinicians out there. If you'd like to order a fluoro-guided lumbar puncture, don't consult IR. They don't do those at UT. Instead, just place an imaging order, just like ordering a chest x-ray, ordering an XR lumbar puncture with fluoro, or you can call for assistance at 645-RADS. So I'm a neuroradiologist, and I just want to talk a little bit about what we do. Our primary clinical duties are interpreting about 3,000 imaging examinations a month of neuroradiology studies of the head, neck, and spine. But in addition to that, we also have a fairly active spinal procedure service, which a lot of you may not realize. So we do about 120 spinal procedures a month. And those primarily include lumbar punctures with intrathecal chemo injection, myelography, spinal biopsies, therapeutic injections, including epidural or transfemoral steroid injections, facet injections, sacroiliac injections, epidural blood patches, and of course, vertebroplasty and sacroplasty. So enough about what I do. I came here to talk a little bit about back pain. So back pain is the second most common reason that adults consult their primary care providers following upper respiratory infection. And up to 70% of adults will experience a back pain episode sometime during their lifetime. And at any given point, about 30% of adults have active back problem. So it's kind of a big problem. And as far as costs go, a study back in 2008 by JAMA estimated that about $90 billion is spent annually for the diagnosis and management of low back pain. So, and then there are additional costs, up to 10 to 20 billion in economic losses each year. So, how does that stack up with other major medical problems? It's pretty much up there with all the others: arthritis, cancer, diabetes. Of course, all those are dwarfed by heart disease and stroke. But it's a big problem. So what can we do to help control those costs? So one is following the Image Wisely guidelines. And so acute, uncomplicated low back pain or radiculopathy is a benign, self-limited condition that does not warrant any imaging studies. And imaging is only considered in those patients who have had up to 6 weeks of medical management and/or physical therapy that resulted in little or no improvement. And there is, so is it okay to wait 6 weeks? So this has been studied, and there's some evidence to support this. And I just want to go over one study done by Modic et al., and it was looking at patients who were imaged early with MRI and to see if that had any effect on their conservative care management. So this is what they wanted to determine. One, what are the MR imaging findings in acute low back pain? 2, what's the prognostic role of these findings? 3, what's the effect of that diagnostic information on outcome? And these are their methods. They enrolled about 246 patients with acute onset of low back pain or radiculopathy. They were all imaged early with MRI and randomized into either an early information arm of the study, where the results were provided within 48 hours, or a blinded arm of the study, where both the physicians and the patients were blinded to the results unless the information was critical to patient care. And here are some of their results. So herniation was identified in about 60% of those patients at the initial examination, which is an increase from the average incidence of asymptomatic patients of around 30%. And that prevalence of herniations was similar in patients who presented with either low back pain or those that presented with radiculopathy. And what they found was that the patients who presented with a herniation at baseline were more often to show an improvement at 6 weeks in their Roland function score, and that improvement at the 6-week follow-up was similar in both the unblinded and blinded groups. So the patients improved whether they knew their results or not. So in their conclusion, in typical patients presented with uncomplicated low back pain or radiculopathy, MR imaging early does not appear to have measurable value as far as terms of planning conservative care, and that the patient knowledge of those findings, or the physicians for that matter, doesn't alter their outcome. So again, back to imaging wisely. For uncomplicated acute low back pain or radiculopathy, imaging is not indicated early on until the patients have failed some conservative management. So is it okay to wait 6 weeks? Yes, in the absence of red flags. So I want to go over some of those red flags with you. So it is indicated early on in patients presenting with symptoms of serious underlying conditions. So what are some of those red flags? If you suspect infection or neoplasm, such as a history of cancer, unexplained weight loss, immunosuppression, urinary infection, IV drug use, prolonged use of corticosteroids, or not responding to conservative management, then imaging is indicated. Other red flags include if you suspect fracture, so if they had a history of significant trauma or even minor trauma or a heavy lift in a potentially osteoporotic or elderly individual, or if they've been on prolonged use of steroids. Other red flags are cauda equina syndrome or severe neurologic compromise. So acute onset of urinary retention or overflow incontinence, loss of anal sphincter tone or fecal incontinence, saddle anesthesia, or global or progressive motor weakness in the lower limbs. Any of these is a neurosurgical emergency, so imaging is indicated and consult a neurosurgeon. So you get imaging and you have positive results. What next? This is an example of an MRI of the thoracic spine. It's a T1 weighted, and we have this low signal lesion down here in the lower thoracic spine. That's likely either a primary or secondary malignancy. If they have a history of primary malignancy, it's suspected MET. If it doesn't change management, it probably doesn't need biopsy. If it does change management, then you can work it up, CT or MRI, and order a biopsy. And again, this is just as simple as ordering a chest x-ray or a lumbar puncture. You just place an order for a CT-guided spinal biopsy. And our radiology schedulers will route it to the appropriate personnel. Or you can just call our number. Same thing for vertebral compression fracture. This is a T2 weighted with stir sequence, which enhances the fluid signal and decreases the fat signal. And that enables us to see compression deformities that have active inflammation. So things that are bright here are active inflammation. These two levels have actually already been treated with vertebroplasty. This patient had new back pain. There's increased signal at the superior end plate of this T12 vertebral body, and then also up here there's height loss and signal abnormality. So you would correlate where their symptoms are, and if they have imaging findings that are consistent with acute or subacute compression fracture, then they may be candidates for vertebroplasty. We do need to see a CT or an MRI. MRI is preferred because we can see if that lesion is still active. But what we are really looking at to see if there's significant retropulsion or cord compression. And if the patient has failed conservative management, they may benefit from vertebral augmentation, and it's, again, as simple as ordering a vertebroplasty or kyphoplasty, or call our number. So, things to remember prior to any spinal procedure is, one, we want to correct their coagulopathy. So the numbers that we go by are an INR of less than or equal to 1.5, or platelets greater than 50,000. And you want to hold their anticoagulants because we don't want them to be at a risk of bleeding. When we place a needle in the spine, we're not able to compress that region. So for heparin, it's typically the scheduled dose that they're getting their medication. So for subcutaneous heparin, it's typically about 8 hours hold. For Lovenox, depending on if it's a prophylactic or therapeutic dose, it's 12 to 24 hours. For NSAIDs, we like 1 to 4 days. Plavix, that's usually the longest, 7 days. And factor Xa inhibitors, 3 to 5 days. Coumadin is typically a 5-day hold, and you need to confirm that their INR is less than or equal to 1.5. You don't have to remember all these numbers. Our nurses and schedulers, have a list of meds to hold, and they can counsel those patients once those patients are scheduled for a procedure. This is the other question we get a lot: when to restart those anticoagulants. So for inpatients, We can actually start the heparin back up 2 hours after the procedure unless it was particularly bloody. Most of our procedures are percutaneous, and blood loss is like less than a drop. So those can be started sooner. All others, we like to wait 24 hours. So here's just a list of what we can do if your patients have back pain and you need some assistance with management. We can do lumbar punctures, intrathecal chemo injections, myelography for working up their radiculopathy, spinal biopsy, CT or fluoro-guided, therapeutic injections, blood patches, vertebroplasty, kyphoplasty, sacroplasty. Here's who to call, 645 RADS. We can also be reached at the multidisciplinary spine clinic or our neuroradiology offices. And I just want to thank you for your attention.